Fresenius Medical Care recognizes that our responsibility to people with kidney disease covers not only all forms of kidney disease, but all stages of kidney disease. And transplantation is probably the optimal treatment for kidney failure if a person is a good candidate for a transplant.
But getting a kidney transplant is not an easy process. Referral for a transplant, getting on a wait list, and sharing medical data among a complex web of providers and organizations have historically been some of the challenges people with kidney disease face in trying to get a kidney transplant.
The referral process is challenging. We've got to gather a lot of records for our patients to send the referral over because the transplant centers need to see the full picture of the patient. During the evaluation process, where is the patient? What have they gone through? What do they still have left to do? And then the waitlisting process, what do they need to get tested for throughout the month? What is it that the transplant center is waiting for? And where are they on the list?
The challenge we find is when we talk about access to transplant, we sometimes forget that that includes first access to a waiting list, which if we look at the data carefully, it shows us that only about 1 in 5 incident dialysis patients are on a transplant waiting list right now, which now not everybody is a candidate for transplant, but there still are opportunities for us to go and assure that everybody who is that candidate is currently has that opportunity.
Fresenius Medical Care has been a leading advocate for more conversation and collaboration between the transplant and kidney care communities. In 2017, Dr. Frank Maddox and fellow nephrologist Dr. Ben Hippen co-authored a wave-making paper to help start much-needed dialogue.
The goal was to raise a series of questions that the transplant community needed to become a more central part of the kidney care community, and that we needed to work together to identify what are the issues that offer transplant to be used more often as a modality of care, to prepare ourselves to participate actively in the care of people getting ready for transplant, receiving a transplant, and their life after transplant.
We hated that paper. And as transplant surgeons, we wrote a counter paper, and the gloves started coming off. And much to his credit, I get this email, and it said, now that the ritual airing of grievances has been had, do you think we can sit down and come up with something that's meaningful for all of us? Because until we can get the right people all in the room together, we're not going to solve this problem.
Dr. Maddox and I were really arguing for opportunities to create collaborative relationships between the dialysis providers, the referring nephrology practices, and the transplant centers so that patients could have a measure of continuity from being on dialysis to making their way through the evaluation process, to getting on the waiting list, to being surveilled and tracked after they were waitlisted to assure that they were in the best health they could be once they got an organ offer.
Under Dr. Maddox's medical leadership, transplant ultimately became a key focus of the company's clinical and quality agenda, with a goal of expanding access to transplants for people living with kidney disease.
Our first large project is working with a multidisciplinary team to create an IT platform that will provide comprehensive surveillance for all of our patients through every aspect and every facet of the transplant process. Once our transplant IT platform is up and running, we'll have visibility not only in the referral and the status of the evaluation process, but once a patient's actually waitlisted, hopefully we will also have additional visibility into which organs are being offered to patients.
Every transplant center has a different checklist for their referral process. So in Fresenius, we're trying to make the most meaningful referral process possible.
Fresenius Medical Care is not only focused on improving access to the transplant waitlist, but also on addressing other challenges to transplantation, such as reducing organ discard and increasing living donor transplantation, so that more people with end-stage kidney disease can receive transplants.
Discards is for sure a significant problem in our transplant world, but we're making, I think, big strides to improve upon that.
The rate of organ discard in the United States has been constant over the last decade at about 20%. By comparison, some of our colleagues in the European Union have organ discard rates closer to 10%. If we make it possible for our transplant colleagues to feel comfortable taking that additional risk, and if we can convince regulators and payers of the same, then we'll have done something good. We will have mirrored the success that's been realized by our colleagues in the UK and the European Union.
The other thing is living donation. That is the most optimal process for our patients because of access to organs. It's scheduled, they're prepared.
It doesn't make sense to me to talk about the importance of living donation without talking about and acting upon the barriers to living donation that we already know about. That's why Fresenius has joined the American Society of Transplantation's Living Donor Circle of Excellence.
The Circle of Excellence program provides an opportunity for us to express that support in a different way. Our employed colleagues that choose to donate actually have the opportunity to get as much support as they can get during that time of their donation.
Nephrology is really unique. We see our patients more than almost any other doctor in any other subspecialty does. We forge long-term relationships with them. We are in as good a position as anyone to help guide them and navigate through an unfamiliar process to transplantation.